Okay, good morning once again. So welcome back. Today we shall be looking at adrenergic agonists and adrenergic antagonists. So what are adrenergic agonists? We say they are also called sympathomimetics. Okay, these are drugs that act along the sympathetic pathway. Actually, they act when our body, is responding to a sympathetic condition. A body is in danger, and the body is in the mode of trying to adjust to sympathetic mode. Okay, we call them sometimes sympathomimetics. The mechanism of action of adrenergic receptor activation, we said there's direct mechanism and also there's indirect mechanism. How do they work through a direct mechanism? Here we said receptor activation through direct binding of the dopamine or epinephrine or isoproterenol or ephedrine. So this one is through direct binding of these amino acids. Okay, can be dopamine or the epinephrine or isoproterenol or the ephedrine. So once this one binds to a receptor and then already it activates a sympathetic response. Remember, we know that epinephrine is one of the hormones that is produced and goes into its concentration increases in the bloodstream when once we are exposed to a sympathetic condition, okay, like what we call fight and flight. For example, you are going on the road, all of a sudden you see a snake, okay, and all of a sudden your body is prepared in the sympathetic response mode. Okay, you need to act right now. It's either you fight the snake, you get a stick, or you beat the snake, or you have to flee. You have to run away. Okay, so at that moment your body is already in a sympathetic mode. You either need to fight or you need to run away. And this happens because of a quick action of all these sympathomimetic uh, response due to the epinephrine that is produced, okay, or even dopamine. Now, the second response can be to the indirect mechanism, okay. In the indirect mechanism, we have promotion of norepinephrine release. We have drugs like the amphetamine, okay, ephedrine, as an example of that. They act indirectly through promoting the release of norepinephrine, which acts also like epinephrine in the same way by stimulating the sympathetic pathway. Or they can act by inhibiting the uptake of norepinephrine. Okay, they inhibit the action of norepinephrine. So one thing is that this epinephrine or norepinephrine they are released at the synaptic cleft. Okay, at the synaptic cleft. So what happens is that once a sympathetic action happens, epinephrine is released in the nerve endings, the synaptic cleft of the nerve endings, and then they take time within the cleft, and then in a short time they are degenerated. Okay, they are metabolized because of enzyme, and then they are broken down, and then their axons are no longer there. So after running away from the snake, this one goes down because already you have escaped the danger. So what happened is that this drug acts indirectly by making sure that there is no quick degeneration of this epinephrine that is already released, additional epinephrine that is already released within the synaptic cleft. So it will inhibit its reactive reabsorption so that it remains there and then it prolongs the action or the response so that you are still in that continuous mode of responding for the sympathetic action. Maybe this is you are trying to fight the snake and you are getting stick and trying to beat the snake is jumping here and you are still focused. So you need more time and you're just there. So this is how sometimes indirectly it works. So direct binding through the receptor or indirect through promotion of norepinephrine release and then inhibition of the uptake of norepinephrine and also inhibition of the monoamine oxidase inhibitors. So we talked previously about the MIO, which is the monoamine oxidase enzymes. So these are a kind of antidepressant, drugs, antidepressants, so that so they keep you alert. They don't they don't they help you from getting away from that depressing mode that is taking you down and you're very dormant. So at least they keep you alert. Uh, let's look at the amino acids called catecholamine or non-catecholamines. These are also some forms of medications. We said extensive metabolism by the liver or intestinal enzymes cannot be used orally for the catecholamine. They undergo rapid metabolism and results in a short duration of action and suitable for continuous IV infusions only because of their quick rapid metabolism. They also have minimal CNS effects due to their polarity, and they cannot cross the blood-brain barrier. This BP stands for blood-brain barrier. They are not commonly used clinically due to their short action duration. Let's look at the non-catecholamine group. This one can be used orally, not extensively metabolized by the liver enzymes. Okay, so because of that, we can take them orally because a portion of it will be able to work in the circulation. Uh, the slow metabolism leads to a longer duration of action. So because they are not extensively metabolized by the liver, meaning and their metabolism is very slow, this means that the duration of action is long, and the frequency of dosing might be a bit longer, not like so frequent because it takes time to happen. More moderate polarity allows them to cross the blood-brain barrier. So this is the opposite of those ones. But solamines cannot cross. But these ones have they have moderate polarity and these drugs can enter the CNS, okay, resulting in CNS effects. So the problem is also that because they cross the blood-brain barrier, some of their effects can also, side effects also manifested in the central nervous system, such as excitement and also nervousness. Somebody takes the drug and because of side effects becomes more excited and also a bit nervous sometimes. Adrenergic receptor and drug specificity. We said there are 5 subtypes of adrenergic receptors. We have alpha 1, alpha 2, beta 1, beta 2, and then the dopamine. Okay, all these are adrenergic receptors. Different adrenergic receptors agonist drugs exhibit variable receptor specificity and activation. Receptor specificity is relative but not absolute and depends on the dosage of the drug administered. So you will have to take your time and appreciate this table a bit. This is just an extract summary of trying to classify the adrenergic receptors and then the cholinergic receptors. So also the adrenergic receptors are the sympathetic drugs, those that put us in the sympathetic mode. And then the cholinergic receptors are the parasympathetic, those that put us in that relaxed mode when we are really at rest. Okay? Here, under the adrenergic receptor, we have the alpha 1 and then the alpha 2. Okay? The alpha 1 group, we have the norepinephrine, the dopamine, the phenylphrin, and then the epinephrine. Okay? The alpha 2 receptors, we have the clonidine, guanfacine, methyl dopa. Okay, methyl dopa is here, you can see that. And all these have a positive effect. They have a positive, they are stimulants. Actually, they are stimulants of the adrenergic sympathetic pathway. And then this negative means they are inhibitors. Okay, they inhibit the effects. So we have phenoxybenzamine, pentolamine, carvedilol, labetalol, fragiosin, teragiosin, dexagiosin, tamsulosin, and silodosin. Again, we have phenoxybenzamine and pentolamine. Now let's come to the other arm, the cholinergic receptors. So parasympathetic mode when we are at rest. Okay, there's no stress, and so we have the acetylcholine, which is a positive parasympathomimetic. Okay, it favors the action of parasympathomimetic. And then the atropine is the opposite. This is like inhibitory. It inhibits the influx of parasympathetic pathway. Again here, still under the adrenergic, we have the beta 1. So we have looked at the alpha, we have the beta 1, and then the beta 2, and then the beta 3. We have the positive ones, okay, and then the inhibitory one, you can read about them. There are quite a number of them. And then dopaminase is here, we have only dopamine. Clinical consequences of alpha-1 activation therapeutic uses. We said homeostasis, okay, like control of bleeding, okay, vasoconstriction, like platelet during injury, what happens to the vessels and platelet aggression or aggregation and all those kind of things in the control of bleeding. All these are manifested to the alpha one activation process. Also nasal congestion, okay. They can be used as an adjunct to also local anesthesia. Some of them use them as local anesthetics. They counteract also hypotension. Remember, we talked about vasoconstriction, but also hypotension is the opposite of that. Uh, they can facilitate eye examination. They can be used during eye examination, okay, because some of them, like pentoramine, they can increase the pupil size. This becomes like one of the adverse effects. They can also be used in hypertension and then local tissue necrosis, extravasation. These are some effects causes because of, of too much vessel constriction, and if it becomes too much, it can cause tissue necrosis because blood supply will have been diminished because of too much constriction of the arterioles. It can also cause bradycardia. So all alpha 1 agonists used intravenously high alert medication, and as medication errors can lead to hypertensive crisis. So sometimes also administering this drug can slow down the heart rate. Bradycardia means slowing down the heart rate. So it should be used with caution. In line with that. Let's look at the direct alpha 2 peripheral nervous system activation has no significant clinical consequences. And then the CNS activation alpha 2 receptors reduces sympathetic outflow to the heart and exhibits analgesic effects. We normally use them in hypertension and also pain relief. We now look at the clinical consequences of the beta 1 activation, all due to activating beta 1 receptors in the heart. What they do is they cause increased heart rate, increased force of contractility of the heart, increase the atrioventricular conduction, and the therapeutic uses are in also heart failure, in shock, as they can increase the blood pressure, or the tissue perfusion, atriovenous block in cardiac arrhythmias, okay, when the heart rhythm is altered until a pacemaker can be implanted. Can also uh, be used in cardiac arrest or assisted. Assisted is when there is total absence of contraction of the heart. Okay, and the adverse effect can be tachycardia or there's arrhythmias. Okay, but rhythm of the heart or even angina pectoris. Angina pectoris like ischemia. The blood supply to the heart is getting inadequate. Still looking at the consequence of beta 2 activation, therapeutic use, said mainly in the lungs. The beta 2, so the difference you need to know that the beta 2, contrary to the beta 1, the beta 2 acts mainly in the lungs, and their action is just bronchodilation. And most of the beta 2 agonists are the ones that we use as asthmatic drugs. Okay, they cause bronchodilation as in asthma. What happens in asthma is that an asthmatic patient has bronchoconstriction, but we use bronchodilators to help this airways open and the person can achieve gaseous exchange at the required levels. So selective beta 2 agonists are used for angina patients, and the adverse effects can be hyperglycemia and also tremor, especially beta 2 receptors in skeletal muscles once they are activated. Clinical consequence of dopamine activation therapeutic use, we said they dilate renal blood vessels and therefore increasing the renal blood flow, that is the perfusion. Manage shock by reducing the risk of renal failure. Let's look at anaphylactic shock. It says severe allergic reaction resulting in bronchoconstriction and brutal edema and increased blood pressure. This is what happens during anaphylactic shock. There is vasodilatation. The increased blood pressure is because there is there is vessel dilatation. So too much vessel is dilating, and most of the blood is pulling away from the is kept at the periphery, is pulling away from the center, from the heart, and then there's really increased blood pressure. Causes can be through a bee sting. Okay, somebody gets bee sting and gets into anaphylactic shock. Okay, or somebody who has eaten shellfish, or even certain drugs can cause this. Somebody is injected maybe with penicillin and is allergic to it. Immediately, somebody goes into anaphylactic shock. A treatment with IM epinephrine, IM epinephrine sometimes can cause that. It involves activation of multiple adrenergic receptors involving beta 1, beta 2, and also alpha 1 to counteract the effects of anaphylactic shock. Use of EpiPen, which is an auto-injector, and the importance of seeking medical attention after use can be beneficial. We look at adrenergic antagonists. So we talked about the agonists, the ones that supports the adrenergic axons. Now we're looking at adrenergic antagonists, the ones that oppose the axons of adrenaline. Okay, we said alpha adrenergic blocking agents. We have others are non-selective, while others are selective. So let's look at the selective ones. When we talk about non-selective, we look at how they attach to the different receptors. So others are selective to specific receptors, but others are non-selective. It affects all the receptors involved. So we have pentolamine blocks alpha 1 and alpha 2 receptors only. So this one blocks both 1 and 2, so it is non-selective. It covers all the alpha 1 and alpha 2. While alpha 1 selective is the one called prazosin, and this one blocks alpha 1 receptors. The importance here is that if we need a drug that should only be intended for alpha 1 receptors, we can use prazosin instead of using pentolamine, because here we will have prevented an adverse reaction that can because of involving alpha 2 receptors. Beta adenosine blocking agents, we have also the non-selective agents like for propranolol, labetalol. These ones block both beta 1 and beta 2 receptors, and even include alpha 1 receptors. While we have beta 1 selective ones like esmololol, these ones are specific to B1 blockers just the same way as prazosin does, only to alpha 1 receptors. Clinical consequences of alpha blockade therapeutic uses, we said sometimes they can cause essential hypertension. Essential hypertension is hypertension of somebody who is already almost pre-hypertensive. Normally, blood is defined as a blood pressure systolic of 140 and then diastolic of 90. A hypertension from overdose of alpha agonists. Okay, and then there's what we call benign prostatic hyperplasia. This is a benign condition that causes enlargement of the prostate in men, especially over men over 40 years. But of course, they are saying these drugs can induce this even if you haven't reached that particular age. Raynaud's disease. We also have attention deficit disorder. We have PTSD, post-traumatic stress disorder, or nightmares, adverse effects. Orthostatic hypotension, reflex tachycardia, nasal congestion, ejaculation inhibition or impotence. There's a safety alert here is saying all alpha antagonists used intravenously are high alert medications, as medication errors can have adverse. So this is a question that we have to undertake. Okay, we are looking still at the clinical function of beta blockades therapeutic uses. It said it's used in angina pectoris in the treatment of hypertension, management of cardiac dysarrhythmias, treatment of myocardial infarction, heart failure, hyperthyroidism, pheochromocytomas, glaucoma, adverse effects. The adverse effects can cause slow down of the heart rhythm, bradycardia, increased cardiac output. So when there's bradycardia, that means already the heart is not also pumping enough blood volume, so decreased cardiac output, and then reborn cardiac excitation. There can also be bronchoconstriction, which is contraindicated if this is an asthmatic patient and there's bronchoconstriction, then this worsening the condition, can also cause hyperglycemia and also clinical depression. Indirect acting and adrenesics, we say two types, both act presynaptically in the presynaptic cleft. We have the central nervous system acting. We have cholinidin stimulates alpha 2 receptors, thereby increasing norepinephrine release in the central nervous system. The PNS is a peripheral nervous system acting one. We have recepin. This one causes decreased norepinephrine synthesis and release and acts as a direct postsynaptic adrenergic receptor blockers. Let's look at the central acting anti-adrenergic drug, which is cholinidin. Starting with cholinidin, this one stimulates alpha 2 receptors, leading to reduced norepinephrine release postsynaptically from the synaptic cleft. Indications in hypertension, pain, and also ADD, okay, as attention deficit disorder. Investigational use, we said opioid withdrawal, smoking cessation. So these ones can help someone who is trying to withdraw from opium or smoking cessation, okay, or what we call Tourette syndrome. The adverse effects, CNS diffusion, rebound hypertension if suddenly discontinued. So when you are stopping this drug, it should be tailored by breaking down the dosage in a prolonged period of time. Embryo toxic, it's also toxic to the embryo, okay, but also can be abusable drug, okay, because it causes euphoria and hallucinations, and people may just take it just because they want to feel high, they want to feel the euphoria. Guanabenge and guanafacine, this is a similar pharmacology to cholinidin, and then they are used for hypertension and attention deficit hyperactive disorder. Okay. Methyl dopa, we say it's same pharmacology, prepared treatment for hypertension in pregnancy. We know methyl dopa is the drug of choice we always use for pregnant mothers. The adverse effect, it might also cause hemolytic anemia and hepatotoxicity, liver damage. Conclusion, adrenergic agonists and antagonists play a crucial role in various clinical applications, and understanding the mechanism of action and clinical consequences is essential for safe and effective medical practice. Thank you for being with me. We have come to the end of this session, and see you in the next lecture.